dysphotopsias were also minimal. Only 8% patients were presented with mild hygrowth, mild clear, and starburst. And posterior capsular ossification is also very minimal, which is 11%, and 9% patients undergo jet capsulotomy. This is a short video clip of IOL implantation, basically induced astigmatism following a phacoemulsification cataract surgery. This study evaluates how placing the incision on the steeper axis meridian influences post-operative visual outcome. Okay, so coming towards the background, cataract has always remained a leading cause of blindness, especially in developing countries. A large number of cataract patients already have some number of pre-existing astigmatism, which significantly affects their post-operative image quality. Even a small amount of residual astigmatism can impact visual quality. It reduces overall image quality and increases the dependence on glasses and lowers patients' satisfaction. While toric IOLs can provide predictable correction, they are expensive and often inaccessible. Therefore, we have explored a simple and cost-effective option to reduce astigmatism during routine phacoemulsification surgery. So our objective was to evaluate surgically induced astigmatism and flattening effect following a 2.75 mm clear corneal incision during a phacoemulsification cataract surgery. So this was a prospective quasi-experimental study that was conducted after taking approval from Ethical Review Board in CMS Lahore from March to September 2024. Non-probability convenient sampling technique was used and 142 eyes were included. The patients included had visually significant cataract and undergone uncomplicated phacoemulsification. While the patients who had prior ocular surgery or any trauma or had any corneal disease or dry eyes, glaucoma, diabetic retinopathy, or any other intraoperative or post-operative complication were excluded from the study. So we observed that pre-operative uncorrected visual acuity was greatly improved from 0.758 to post-operative results of 0.144. And coming towards the pre-operative difference in pre-operative and post-operative astigmatism, the astigmatism improved from 0.878. The mean reduction was from 0.878 to 0.645, which was the astigmatism reduction of 0.233, which is small but very visually significant for patients' overall image quality. Impressively, 70% of the patients gained more than 3 Snellen lines. Coming towards the surgically induced astigmatism, the mean surgically induced astigmatism in our study was 0.585. And the target induced astigmatism was 0.450, which was consistent with the studies that have done previously with a 2.75 mm clear corneal incision. And we got a reduction of 0.233, mean reduction of 0.233 in astigmatism post-operatively. A comparative FAIR-T test was applied and to compare the pre and post-operative results of uncorrected visual acuity, corrected distant visual acuity, and astigmatism. All of it showed the p-value was less than 0.001, which was statistically significant. So I conclude my study by saying that our on-axis incision of 2.7 mm results in a low and predictable surgically induced astigmatism and improves the overall vision of the patients. So by placing incision correctly, we can reduce the low pre-existing astigmatism of the patient without upgrading any technique. Thank you, sir. Any questions?
Thank you. how much astigmatism, if it is present, then you go for a toric, otherwise surgical on excess?
So in our study, we found out that the patient who had astigmatism of less than 0.1 diopter, they benefited from this incision. But the patient who had more than 1 or 1.5 diopter of astigmatism, they should go for a toric IOS because on-axis incision was not effective in those patients.
So you have a specifically designed table for temporal approach, or with the same you go move on to the temporal side?
So no, we took such the standard. We took 0 degree at the left side and the 90 degree was what we see on the that side and the 180 was on the right side. Right eye was 180 of the right eye was temporally and 180 of the left eye was nasally. And we marked the patient while the patient was sitting on the slit lamp and in the upright position to minimize the cyclotorsion effect while the patient was lying.
So it was only single incision, or how much astigmatism is corrected by one incision?
So it was a single, the 2.75 millimeter incision was a single incision, and we found out that the patient who already had an astigmatism of less than 1 diopter, it reduced by 0.33 diopter, mean 0.33 diopter. And while we all know that we also induce some astigmatism while we give a clear corneal incision, and from our study we found out that if we give that incision on the steeper axis, we can induce lower astigmatism.
So we all know diabetic macular edema is a leading cause of vision loss in diabetic patients and often requiring repeated intravitreal therapy. And we also know that significant portion of patients show inadequate response to the intravitreal anti-VEGF injection, so leading to the resistant diabetic macular edema. What is our rationale? Due to the limitation and potential side effects of anti-VEGF agents and intravitreal steroid for resistant diabetic macular edema, a suprachoroidal injection has emerged as promising alternative treatment with more results and reduced side effects. So, in our objective, we will evaluate the safety and efficacy of suprachoroidal triamcinolone injection in cases of resistant diabetic macular edema. And what is resistant diabetic macular edema? So, those patients which show the lack of response after 3 intravitreal anti-VEGF injection. Lack of response means that they have less than 5 letters improvement in best corrected visual acuity, and or they have less than 50 micrometers improvement in their central macular thickness. And this we noted after 1 month of 3 intravitreal injection. So, this study was a prospective, non-randomized interventional study conducted at St. Gangaram Hospital last year. We took the 30 patients who were diabetic resistant, who have diabetic resistant macular edema. Inclusion were the same treatment resistant diabetic macular edema, and the exclusion criteria was any patient with macular edema without diabetes, we have excluded that. Patient with increased IOP, patient with macular ischemia, and patient with a cataract, we have excluded all those patients. So, under aseptic measure, we took the 30 gauge insulin syringe, and we also took for 24 gauge cannula, which is used in yellow in color. We took the part of 24 gauge cannula. We put that part on the needle of 30 gauge insulin syringe, and then we trim the upper part such that only the bevel end, or you can say 1 mm part of the needle was exposed. Then 0.1 ml of suprachoroidal injection was injected at 4 mm from the limbus, supratemporal choroid. After applying the injection, cotton tape pressure was applied to prevent the reflex, and we have noted that usually there was sudden surge in the IOP. So to avoid the CRAO and other effects, we do the paracentesis with a 1 cc syringe. Post-injection quarterly antibiotic drops were given, and follow-up was made after 1 month and after 3 months. We noted the best corrected visual acuity, IOP, and central macular thickness. What were the results? There were 30 participants. Mean age was 47. 62% were the male, with the mean duration of disease was 12 plus minus 5. eye involvement was right eye was 38%, left eye was 62%, and mean prior anti-VEGF injection were 6 plus minus 2. These are the results. Actually, I have already published this paper, so I have took that part from my published paper. First of all, best corrected visual acuity. Before treatment, it was 0.83 logMAR, or you can say that it's around 636 and 616 in between. After 1 month, it reduces to 0.56. You can say that it's almost 618 after 1 month. And after 3 months of treatment, it reduces to 0.42%. It's around 6 by 15. So it's actually the mean best corrected visual acuity. We started from 636, and at the end of 3 months, they were 6 by 15, majority of the patients. Central macular thickness was reduced from 486 to 344 after first month. Then after 3 months of that single injection, 245. IOP, from the baseline, there was sudden surge in IOP after 1 month, but that reduces to the baseline after 3 months. So that was also negligible. Thank you. So, in conclusion, I will say that the supracortical is a promising alternative treatment for resistant diabetic macular edema. Thank you.
Why do you experience a surge and rise in IOP after suprachoroidal?
So, because when we put the injection in the suprachoroidal space, there is sudden eye becomes sudden hard because the space is very limited, and we are putting 0.1 ml injection. That's why sclera is not. If sclera is a tough organ, it doesn't expand. That's why there is sudden hard in the eye.
Any questions?
Macular ischemia में patients आपने exclude किए तो कैसे operations किए macular edema?
So macular ischemia.
Ischemia.
Sir, macular ischemia OCT after OCT, it is atrophy of sinus. That's why. Or we have not done the FFA, but it's better if you do FFA.
OCT angiogram किया.
It was not available in our institution.
Okay, thank you very much.
Thanks.
The males, and they received insulin eye drops 1 international units per milliliter. They were given 6 orally for 3 months. And primary variables studied at the end of studies after 3 months were corneal epithelializations, conjunctival hyperemia, and corneal staining. Inclusion criteria were included both genders from 18 to 65 years, and they were all having dry eye disease, and they were not responding to the conventional treatment like extensive lubricant, soft contact lenses, and they were having persistent epithelial defects, and the patient with meibomian gland dysfunctions, patient with anti-glaucoma drops, and rheumatoid arthritis were also included in the studies. Exclusion criteria were included prior ocular surgery, trauma, corneal disease, ectasia, and patient lost to follow-up, and patient who non-consented. After 3 months of topical insulin eye drops, there was significant improvement in corneal staining, conjunctival hyperemia, and there were 50% improvement in corneal epithelializations using Afron gradings, National Eye Institute classification grading, and Vaughan gradings for conjunctival hyperemia. Our results were consistent with Burgos, Bolsko et al. And Zhang et al. Conducted in China and Spain respectively. They concluded that the topical insulin eye drops has ability to modulate cellular metabolism, and they reduce inflammation with improvement in corneal epithelialization as well as the visual acuity. So we conclude that the topical insulin eye drops can be recommended as an effective first-line management option in the patient with dry eye disease because they improve hyperemia, corneal staining, and epithelial defect in our study. It is also simple, cost-effective, and excellent tolerance with the patient of dry eye disease. Thank you.
So, what could be the system?
Normal insulin and shelf life. Shelf life is 2 weeks.
आपने blood sugar level नहीं भैया किया. 100 नहीं किया.
No, sir. Sorry.
होना चाहिए
Sir.
ताकि उसका सिस्टेमिक एब्जॉर्प्शन यूज कर सकते
Sir.
थैंक यू It was a very fruitful session. Good discussion was done, good presentation was there, and they were up to the mark. But one thing I would like to mention that the case studies, only the case reports, they will not be included for honoring or award of any. Right. So it was very effective, and they adhered to the time. I think only one or two, but the rest they did the time, and that was a good point. So we conclude this session as we have already. So next session would be at 10:30. And it's 10:30. We'll be here in the same session. Thank you very much.
Violence is worldwide. It occurs especially in young males with occupational areas. As Gujranwala Medical College is one of the only hospitals in Gujranwala division which deals with ocular trauma, here are few of the videos which show removal of foreign bodies. In this video, we can see a 7 o'clock deep intrastromal foreign body. We try to remove it from its interior surface, which failed. Then we had to take entry into the AC, maintaining AC with viscoelastic gel. And so, when applying slight pressure on its posterior end, it came out from its interior surface. We applied stitches at 7 o'clock and at the entry side. In this video, we can see a foreign body at 7 o'clock. We are maintaining the AC with viscoelastic gel. We enlarge the incision. Here you can see the foreign body. If I can get a pointer. We inserted the foreign body forceps and carefully held the foreign body and took it out of the AC. This is the foreign body being removed. It is out. Here again, you can see a foreign body at 3 o'clock. We are taking our entry here. We will inject viscoelastic gel using the person forceps, slightly pulling on it and removing the foreign body. This third case is a case of foreign body in the posterior segment. This patient presented with high velocity metallic trauma in his eye. The entry wound was closed. We did pars-manovitrectomy and removed this foreign body, as shown here. The common causes of foreign body include high velocity metallic objects while hammering, drilling, etc., road traffic accidents, agricultural tools, even animals like horn, beaks cause trauma to the eye. Sharp objects at home can cause severe injury to children at home. How can we prevent it? We know that prevention is better than cure. By simply adopting few measures at home, we can prevent our vision loss. Primary prevention includes, first of all, we need to stop the entry of foreign body into the eye, which can be done by using polycarbonate face shields and goggles, and by educating the workers about protective gear and first aid management, fireworks safety, and during sports like paintball and archery, we should always do them while using protective gear. Public awareness plays a very crucial role in preventing ocular trauma. We did many seminars. We use platforms like social media and news channels to spread awareness. We even conducted many research articles at our setup, one of which showed 70% reduction in firework injury over the span of 1 year. Secondary prevention is preventing the eye. Protect the eye. Do not try to remove the foreign body yourself and refer to the ophthalmologist as soon as possible. Tertiary prevention is mainly prevention of complications like endophthalmitis, retinal detachment, cirrhosis bulbar, charcosis, and visual rehabilitation. The key home message today is that we all need to protect our eyes. Only then we can enjoy the beauty of this life. Thank you. Any questions?
So, which was the most common type of trauma?
So usually the superficial corneal foreign bodies come in our setup. And these are easily removed with set time. We put an encane drop and we remove it using an insulin syringe. These are the most common that we see daily, almost daily.
Because your waste and industrial
Yes.
city and the time.
Even at night, 12 o'clock, 1 o'clock, they come to this.
So safety measures. What are the various safety measures?
Like you said, it's an occupational area, industrial area. We really need to educate the workers there about their own protection, and we should tell them that they should inform their owners that this is their right. They should use goggles, safety. They themselves also avoid using it. Most of the vendors they come, they say sometimes we wear it, sometimes we don't wear it. They need to know that it's very important for them. And while removing the protective measures, I would say okay, when we are removing, we should be careful. Okay, we should just remove the foreign body, not cause more damage to the eye itself. Like we are using viscoelastic for it, not damaging the lens or endothelium.
आपने जो वीडियोस दिखाई ये सब आपके सेटअप की ही है और आप वहाँ पे क्या पोस्टीरियर सेगमेंट में से भी रिमूवल की फैसिलिटी है?
Yes, we do remove posterior segment foreign bodies as well.
Easy with the piece microflow 1, 2, 3 in terms of ease of IOL placement and complications. We have seen a major evolution in IOL delivery techniques. The shift from manual loading systems to the pre-loaded injectors has reduced surgical time, improved sterility, and reduced predictable incision size. Our main objective was to compare the clinical performance of two preloaded systems, and the key question guiding our research was, does the type of injector system have the surgeon reported ease of IOL placement and complications? We conducted a randomized clinical trial of a period of 6 months. The total eyes were 50, which was equally divided into two groups. Inclusion criteria include patients between 18 to 80 years and the patients diagnosed with cataracts. Exclusion criteria include patients with concurrent eye conditions and with intraoperative complications other than the damage to IOL injector. The EZA is made up of the hydrophobic acrylic material and it utilizes a plunger system in a preloaded injector. While Micropure 1, 2, 3 is made up of glistening-free hydrophobic acrylic material and it has a hybrid screw and plunger system and it was delivered by a single-use injector 1, 2, 3 premium. To make the fair comparison, all the surgeries were performed by a single surgeon using a standard protocol. We used 2.75 to 2.8 mm clear follicle incision and 2% hydroxypropyl triacylose gel was used. And to evaluate the ease of use, we used a grading scale and it was scaled by the operating surgeon. Now coming to the results, our first parameter was the lens insertion time, and we calculate this from the assembly of the lens in the cartridge to the intra-black placement. And for the EZA, it was 32.28 seconds. For the Micropure, it was 54.36 seconds. Now I discuss the surgeon reported difficulty of lens implantation. Almost 80% cases of the EZA were rated as easier than most or very easy. However, for the Micropure, majority of the cases were rated as average. Now I compare the injection technique and IOL delivery. About 90% cases of the EZA were the injection techniques were smoother in the AC. So in 80% of the cases, the lens was delivered directly into the back without the need of stepping or additional instruments. However, for the Micropure, majority of the cases were root assisted and leading it was delivered in the back. And the second instrument was needed in almost all the cases. For the EZA, we had noted a small complication of haptic sticking with the optic, and with the case Micropure 1 to 3, it showed no damage to the IOL injector. This video shows the EZA injection system. This comes in the dry form. You can notice how easily the nozzle gets into the AC and the lens is delivering directly into the back. And most importantly, the second instrument is not needed. In the second video, this is the case Micropure injection system. This comes in the wet form. And you can see the nozzle doesn't get into the AC and the lens leading haptic is delivered into the back. And the second instrument is needed to make the lens to make the final position of the lens in the back. So overall, the EZA performed significantly better in terms of insertion time, ease of IOL placement and relief for second instruments, and the main reason was the nozzle in the AC delivery, which led to the intra-back delivery and less manipulation. While Micropure required more assisted delivery in majority of the cases and required more manipulation. and it showed excellent haptic behavior with no haptic damage, while with the EZ, a minor complication of haptic sticking was noted. So to conclude, both the devices are safe with negligible interoperative complications, and we have seen for the efficiency and the ease of use, the EZ systems offers faster, smoother implantation with minimal instrument use. However, in terms of the device performance, MicroPure 1 to 3 remains stable with no applications. So, from our experience, we recommend using the ringer update or balanced electrolyte solution when working with the EZ system for smoother delivery. However, for the MicroPure, we recommend the taper the nozzle design, and that will likely improve the ease of entry into the ventilator. Thank you. Any questions?
Thank you very much, Dr. Sabra. Now we move on to Dr. Aksa Baloch for a talk on effect of lenticular opacities on measurement of retinal nerve fiber layer and ganglion cell complex thickness using OCT.
Department of Ophthalmology, Gujranwala Medical College Teaching Hospital. Today I'll be discussing on this interesting topic, effect of lenticular opacities on measurement of GCC and RNFL thickness using optical coherence tomography. Just a brief introduction, what is glaucoma? It is a chronic progressive optic neuropathy characterized by optic nerve head changes and visual field defects. But IOP is a key modifiable risk factor. And with the evolution of modern technologies, early diagnosis of glaucoma is now possible. But adequate examination, IOP, perimetry, and OCT are usually sufficient to warrant a justified diagnosis of glaucoma. And in this, the LOGS-3 classification was used for the cataract grading in our study. The objective of the study was to study the effect of lenticular opacities on measurement of ganglion cell complex and retinal nerve fiber layer thickness using optical coherence tomography. This was a prospective cross-sectional study, and it was done in our prestigious Department of Ophthalmology, Gujranwala Medical College Teaching Hospital, from December 2024 to January 2025. It included 50 eyes of 50 patients, that included 30 males and 20 females, and mean age was 54.6. Only those patients were included in which OCD data and signal strength was sufficient enough to provide the data, and it included both genders. It excluded all patients who had dense cataracts, who had age under 18 years, and who were somehow unable to undergo OCT procedure due to their uncooperative behavior or any systemic disease. The method that we used was OCT was done pre-operatively before cataract extraction, and cataracts, as I earlier mentioned, were classified according to LOGS. And all patients underwent phacoemulsification by the same surgeon. OCT was repeated in all patients 1 month after the procedure to provide the GCC and RNFL measurements. The results, as you all can see, were clear enough. Mean RNFL thickness before surgery showed to be average 84.3, which after surgery showed to be 90.9. And mean GCC thickness showed to be 86.7, and that showed to be after surgery 93.5. So concluding my topic, lens opacities usually reduce signal strength in OCT, causing false reduction in mean RNFL thickness measurements. So cataract extraction usually improves signal strength and thus increases mean OCT parameters. Thus, OCT can be misleading sometimes pre-operatively. Hence, however, a detailed examination, IOP, and perimetry is needed to a confirmed diagnosis to glaucoma. Thank you.
Does the type of intraocular lens which was implanted also have an effect? Cataract does affect, but the IOL was same in all these patients or?
Hanji sir, they were all the same, but it was not evaluated in the study. The iron material is affected. As I have assessed this in based on the lenticular opacities, the OCT measurements. So it depends on the postocular inflammation and the clear media that would give the sufficient OCT and GCC measurements. We can do it 1 month post-operatively as soon as the cornea clears and as soon as the post-op inflammation has settled.
Does it matter कि अगर हम first post operative करेंगे third पे या 30th पे उससे भी reading pay करता है?
It won't usually affect if your first day cornea is clear and there is no further opacity, uneventful case and ocular inflammation has settled. Then no matter if you are doing it on third day or first month, it would be the same.
You excluded patients under 18, like cataract can happen at any age, but cataract. Would that also affect the study?
Definitely it would affect it because OCT is reliable above 18 years of age, and if we do it under 18 years of age, that wouldn't give reliable measurements.
Okay. What grading of NS usually affects this thickness levels?
NS plus 3 and above would affect it.
Okay, thank you very much. Any questions further?
I'm Dr. Hari Malik, and I'm a second year resident in Ophthalmology Department of Shamala Medical College. Today I'll be sharing with you an interesting case of a 12-year-old girl who presented to us in the OPD with complaints of pearly stone-like formations coming out of her eyes every 2 to 3 hours, as you can see over here, while actually, and she also had symptoms of itching, watering, and redness for about more than 2 weeks. Okay, we got a little bit of history. She gave history that she had an episode of fever and fits at the age of 6 months, but no record was available and no episode was ever since recorded. And she also had developed some dermal lesions on her face which were not tended, and she developed it at the age of 2 years. Okay, so family history was positive for these dermal lesions. 2 out of her 6 siblings will have the similar dermal lesions, and the father also. And her father and one of her siblings had also history of seizures and epilepsy. And one of her brother died at the age of 22 years. He has a headache and also an occipital region mass, and he also had a similar dermal lesions. Okay, so this is the other eye examination. They used to develop every 2 to 3, 4 hours. Okay, so ocular examination was normal, except we found that there were palpebral conjunctival reaction, which was mixed papillary and follicular. Other anterior segment was normal. Thalassomy was normal. She was 6'6" bad actually. These are the posterior pole examination of both her eyes, which are constantly normal. But we found a flat hyperpigmented lesion in the left eye, which was about the size of 1.5 inch diameters. It was well demarcated and near the infratemporal arcade, and it doesn't have any new vessels around it. Okay, we referred the patient to the dermatology department, and these were the positive dermatological findings. There were multiple skin tags on the face, hypomelanotic rectums are present in the back, shagreen patch, which are present in the sacral region. There were dental pits in the teeth, and also angiofibromas, which were more than 2 on her forehead. There were no other lesions on her fingers. Okay, MRI brain with IV contrast was also advised, and we found out there were cortical tumors and also subependymal giant cell astrocytomas, as you can see over here in the bilateral ventricles, lateral ventricles, also right here. Okay, we also sent these conjunctival confusions for the histopathology, and it showed acute or chronic inflammation along with the degenerative epithelial squamous cells and keratinomegaly. Other investigations like CBC, echocardiography, ultrasound, and ECG were normal. So a diagnosis of tuberous sclerosis complex was formed. It is also a dominant condition which occurs mutation in chromosome 9 and 16, according to protein's involvement in the cell growth and the manifestation of the disease and hematomas, which are abnormal growths and normal regions present in many organs of the body. Okay, so the retinal findings that we can see are of 3 types. The first one is a flat hypopigmented lesion. Second one can be raised, calcified and pulmonary lesions. And the third one are transitional zones in between. Our patient had the transitional zones.
transitional lesions. And also they do not affect the visual acuity unless they are present on the macula. Okay, so conjunctival conditions, they are actually formed due to chronic inflammation, allergy, dry eye symptoms, or infective disorders, which are made of degenerated epithelial cells and keratin material, which can become confluent in the inferior cornices and may erode and become confluent and become symptomatic. So the management for the conjunctival symptoms was done by using the antihistamine eye drops, masters, stabilizers, and lubricants, and the retinal dermatomas were advised to follow up for every year. Neurosurgery referral was also made. They also advised the patient for regular follow-ups, and dermatological symptoms were treated with the help of topical ointments and laser treatment. The most important part of this management is screening of other family members who have similar dermal lesions, because the intracranial lesions and the retinal symptoms can be quite symptomatic. Okay, thank you. Any questions?
Yes, please.
You said his brother died in young age, but they don't know why he died. And his father also.
Yes.
So could this happen? His diagnosis as well.
Yes.
Maybe an intracranial.
और जो कंजंक्टिवल साइन सिम्टम्स हमें मिल रहे थे, ये ट्यूबरस स्क्लेरोसिस के पेट साइन सिम्टम्स हैं, क्या ये हमें उसमें मिलते हैं?
It's not always related, and in literature it's also not documented. But it is a hematomatous forming disease. So hematomas can present at any parts of the body, anyone. Thank you.
I'm Dr. Laiba Asif, a third-year resident at Mughal Eye Hospital, and today I'll be talking about small, round, and out of place, a case series about microspherophakia. So moving on to the purpose of the study was to review the clinical presentation, the range of management strategies, and the real-world outcomes in the patients with microspherophakia. The study design was a retrospective case series in which the surgical and outpatient record of the patients presenting to Mughal Eye Hospital and Equity Eye Center from April 2021 and to January 2025 were reviewed. So only patients who had a minimum follow-up of 6 months were included in this case series. So we studied 24 eyes of 12 patients with bilateral microspherophakia. And moving on to the results, we analyzed the results in terms of their demography, their presentations, the incidence of glaucoma, and the visual outcomes, and what was the surgical plan. So 42% of our patients were male and 58% were female, with an age range of 4 to 30 years. In terms of presenting complaints, the most common presenting complaint was decreased vision, which was encountered in 18 of the eyes, followed by a routine checkup, in which the microspherophakia was discovered incidentally in the sibling. And the pain and redness, we had 2 patients. These are the clinical presentations which we encountered. The first picture shows a microspherophakic lens with subluxation. In the second picture, we can see that the microspherophakic lens is bulky and the anterior chamber is shallow. The third picture shows the increased anteroposterior diameter of the lens, which was captured with the help of a topographer. Moving on to the second presentation which we encountered was the bilateral crystalline lens in anterior chamber. This was a patient, these were 2 patients who were siblings. This is the first patient with bilateral lens in anterior chamber, and this unfortunately is the second sibling who also had cerebral palsy. In this unfortunate picture, we can see that the crystalline lens has been stuck on the cornea, causing the decompensation. Unfortunately, this patient also had NPL vision in the second eye because of being operated in the periphery and developing endophthalmitis. This was the most unfortunate case in our series. Moving on to the systemic investigation. 5 of our patients did not have any systemic association. 2 patients had homocystinuria, which was confirmed by measuring the homocysteine levels in urine, as well as plasma. Moving on to the 2 cases which were familial, in which both the siblings had microspherophakia, and 1 patient had B-Marchesani syndrome. Anterior segment findings, as I discussed, 8 patients had microspherophakia, 9 had with subluxation, 1 had corneal decompensation, and lens in anterior chamber with 3 eyes. The management algorithm of these varied presentations was divided as follows. We observed the patients who had stable zone use, good visual acuity. Okay, these were 4 eyes. Moving on, 4 eyes, we did YAG-PI because of prophylaxis of increased intraocular pressure. The remaining eyes underwent surgery. The surgical plan is discussed. These are the eyes. This is a picture showing a YAG-PI in a patient with microspherophakia. Followed by the surgical interventions, the most common intervention in our case series was lensectomy with anterior vitrectomy followed by scleral fixation of IOL. These were 10 eyes. The varied presentations, one eye underwent fast planar vitrectomy and lensectomy because the lens had fallen into the vitreous. These are the intraoperative stills of a patient with microspherophakic subluxation. In the first picture, we can see that the marking of the sides in case anything goes wrong. The second picture shows the initiation of the rexis, followed by the insertion of a CTR and an IOL. Moving on to the incidence of glaucoma, 4 eyes were managed with peripheral iridotomy. 2 eyes underwent micropulse diode in order to control the intraocular pressure, followed after the scleral fixation. 2 eyes were kept on anti-glaucoma medications. The complications we encountered in our study included amblyopia because of late presentation, endophthalmitis. 2 eyes developed retinal detachment, which were repaired. The visual acuity outcomes were best in patients with lensectomy, anterior vitrectomy, and scleral fixation of IOLs. These 6-12 or better vision. 4 eyes were amblyopic with counting finger vision. 1 eye was PL positive because of NVG that developed after RD repair. So the discussion, the varied clinical presentation of microspherophakia should be managed and tailored accordingly to the patient. So early diagnosis and individualized graded approach manage good patients in terms of microspherophakia. So the limitation of my study was that it was a small sample size and longer follow-ups are required. These are my references. Thank you.
Question from the audience.
What are the indications of lensectomy?
So the indications of lensectomy included, first of all, we observe the patients with no subluxation, stable refractive error. In case there is high astigmatism, high lenticular myopia, and subluxation, or the lens is causing increased intraocular pressure, moving the angle because of the presence of a bulky lens, then we move towards the surgery.
In one case, you applied COT, right?
Yes.
What was the reason for that?
So in that case, there was subluxation along with microspherophakia. So in that case, the subluxation was less than 180 degrees. So Sioni ring was fixated and followed by the insertion of IOL.
Did you follow that patient?
Yes, sir, I followed that patient, but the patient was lost to follow up eventually. That patient has a vision of 6-12 pounds up to the record that we have up till now.
What was the age of that patient?
The age of that patient was 17 years.
What complication you can see in long-term follow-up?
Long-term follow-up, we saw RD in 2 eyes. That patient in 1 eye developed neovascular glaucoma because of RD repair, because of silicone oil in the anterior chamber. And the second eye of that patient has 624 vision with repair of, after the repair of RD.
How long did it take to present?
He presented with RD after almost 3 to 4 months of the surgery. He developed bilateral RD. The youngest patient operated on was only lensectomy and anterior vitrectomy. The patient was aphakic, left aphakic. He was 4 years old. Also, in such patients, we encountered amblyopia because of the late presentation and non-compliance to glasses, aphakic glasses.
Assalamualaikum. My name is Dr. Mohammad Turris Farooq. I am a second year resident at Mobile Hospital. And today my topic presentation is an included in case. This is a case presentation of a 30-year-old male, resident of Sheikhupura, spectrum ultraviolet profession who presented to OPD on 2nd March 2025 with decrease of vision in right eye for about 20 days. In history of presenting illness, his decrease in vision was gradual, progressive, painless, and was associated with glare at night. There were no relieving or aggravating factors. On further probing into history, he recalled a trauma 3 to 4 months ago while using a milling machine working with a steel equipment, for which he went to his general physician who prescribed him fluoxetine and dexamethasone combination, which he used for 1 month. As his complaint was resolved, he never went back to the general physician or to any eye doctor for his complaint. Past history was relatively unremarkable. There were no medical or surgical history or ocular history. On general physical examination, he was well oriented in time, place, and person and was widely stable. Moving on to ocular examination, his visual acuity in the right eye was 660 with no improvement, and in the left eye he was 66. On further detailed examination of the slit lamp, left eye was completely unremarkable. In the right eye, there was a 3 to 1 millimeter linear corneal scar at a 4 o'clock position, and the pupillary reaction was sluggish. Next, when we moved towards the lens, there was intercapsular fibrosis at 4 to 5 o'clock, and the development of cataract accompanied by fibrosis, and there was a foreign body within the lens at the same position. So after that, the patient was dilated, but we did not have any fundus in the right eye. The left eye fundus was normal. This is the slit lamp examination at 16x. We can see there is a corneal scar, and underneath that there is capsular fibrosis on the lens, and there is a foreign body. We could not determine the depth of the foreign body as it was encased within the cortical matter of the lens. So as there was no fundal view, we requested a right B scan to rule out any retinal pathology or posterior segment pathology. So fortunately for the patient, there was no posterior segment reaction or any pathology, as there were no vitreous cycles and the retina was flat. Next, we made a diagnosis that it was a right eye traumatic cataract with retained intralenticular foreign body, as there was no AC reaction, so we labeled it as intralenticular foreign body. So moving on to management, we devised a plan for the patient. As he was 30 years old, the cataract was relatively soft, so irrigation aspiration was to be done with retrieval of foreign body and on-table decision of IOL implantation, as we did not know the status of posterior capsule and possible anterior vitrectomy, depending on the situation. So as we have planned, and we have to calculate the risks also. So there was anterior capsular fibrosis, so we may face difficulty in the axis, and the status of posterior capsule was unknown, and the new status was unknown. May need to possibly do anterior vitrectomy, or may need to leave the patient if the sulcus and the bag were disturbed. So to our surprise, there was a big 5 into 3 into 0.5 millimeter foreign body, and this was included in case within the lens. So to our surprise, this foreign body did not disturb the posterior capsule. So we ruled out any cause of anterior vitrectomy in this patient. And this body was almost made of inert matter. The patient was working with stainless steel, so maybe that's why there was no metallic toxicity within the anterior chamber or in the posterior chamber. And as the body was sealed within the cortical matter of the lens, there was no reaction in the anterior chamber. So there were routine steps. The surgery went uneventful, and the IOL was implanted in the bag. So were there any complications? The surgery was relatively uneventful, except for a capsular axis runner at 4 to 5 o'clock position. First day post-op, the patient's vision significantly improved from 660 to 612, and on 1 week post-op, with the best visual acuity of 6.6 with a minus 0.5 diopter surrender at 130 degrees and a near add of 2.5. The successive follow-ups were unremarkable. So, conclusion, every intraocular foreign body is unique. Like this was just an intralenticular foreign body, although it had passed the anterior chamber into the lens, but the capsule was sealed. So, it was inside the lens only. So, and associated ocular damage to achieve the best outcome for the patient. And fortunately for our patient, he achieved the best outcome. Thank you.
Any questions?
What did the investigation could have done to know the extent? You said it was encased in the cortical matter.
Yes.
Some other investigation could have
Yes, we did request X-ray of the orbit to exclude any orbital pathology, but the patient did not receive any film for the X-ray, so that's why we could not. The X-ray was done, but it was on his phone and it was unremarkable. There was no hot body besides that inside the lens. Yeah, it was small.
So, which lens did you use now?
So it was single piece acrylic lens. We had other lenses as as a backup multi-piece and TMMA. But since the bag was undisturbed, we opted for single piece.
Okay, and Vexus was done. Okay.
It ran out at 4 to 5 o'clock near the fibrosis, but it was handled well.
Was there any interventions?
No, there was no interventions. The irrigation aspiration was done just by the simple cannula. There was no even paper. There was no interventions.
Okay, thank you very much. Now we move on to the next speaker, Dr. Noor Fatima, for a talk.
Today I'm presenting a case of related process and process in a female patient 54-year-old presented in an OPD with a complaint of unilateral pain in the left thigh on waking in the morning from 1 week. She also had complaint of double vision, drooping of left upper eyelid, and swelling and feeling of fullness in the left upper eyelid. Patient reported 1 week history of pain in her left thigh, and there was no associated history of fever, cough, joint pains, or trauma, and there was no history of recurrent or chronic sinusitis, pharyngitis, or any weight changes, heel or intolerance, and palpitations. Her surgical drug history, past medical and personal history was also normal. There was no family history of any hematological or malignant conditions or any orbital tumors. General physical examination was normal, and the study examination was also in the normal range, and there was no thyroid enlargement or nodularity. Clinical examination, this was the initial presentation. You can see sclerosis and proptosis of the left eye. This was taken patient consent. This is on clinical examination. Her visual acuity was unaided visual acuity was 6 bilaterally. Her extraocular movements in the left eye were restricted in adduction and abduction, and they were also painful. On the fovea charting, there was horizontal equator in both left and right eye. Palpation, there was no mass of weight in the right eye, but in the left eye there was palpable mass, which was diffusely distributed in the upper orbit. It was soft in consistency, and skin was mobile, non-tender, and was normal temperature. There was a severe necrosis and fibrosis in the left eye, 30 cm, and it was from the left eye. Other examination of anterior posterior segment was in the normal limit. ENT evaluation was normal when the sinuses, both and gravity. Based on the initial representation and history of the patient, we made the differential diagnosis of idiopathic orbital heart disease, thyroid disease, orbital cystitis, orbital tumors, and metastatic tumor, cytosis, keratosis, cholangitis, and lymphoma. So to exclude all these differential lab investigation, CBC, thyroid profile, LFT, RFT, serum angiotensin converting enzyme, ESR, serum CRP levels, AMP levels, and serum ANCA levels were also done. All these lab investigations were normal. So then we went on to the radiological investigations. We did chest and abdomen X-ray. It was normal, showed no mass or higher lymphadenopathy. And MRI brain and orbit was also done. You can see there is enlargement in two series of the extraocular muscles, especially medial and lateral rectus, along with the tendon insertions of the in the left eye as compared to the right eye, and the muscle belly is enlarged with the involvement of tendinous insertions. So epimetal sinus also appear normal, as you can see, and ligament gland is also normal in this MRI view, and orbital fat has hazy appearance at the orbital apex, and there is also consistent with the inflammation. So in this view, you can see the distance from the interzygomatic line to the ear cornea is enlarged in the left eye as compared to the right eye, which is forming the left-sided proptosis. So the elongated axial view MRI showed no intracranial extension in this view. So final diagnosis was based on the radiological and clinical findings, along with exclusion of all other causes of unilateral process and proptosis. We made the final diagnosis of idiopathic orbital inflammatory disease. So after the consultation with medical specialists, patient was started with high dose oral corticosteroids and 8 tablets in the morning and 8 to 9 1 milligram per day body weight. And the follow-up plan was to review within 7 days of starting steroids. Patient listed first follow-up at first week, and then she presented third week with the recurrence of symptoms and necrosis due to non-compliance, and then she was again advised high-dose oral steroids with reassurance. And after this high-dose steroid therapy, this is the final outcome of the patient. You can see resolution of proptosis, ankylosing and her pain was also resolved. So her steroids were then tapered off at the fourth follow-up, and this is the case timeline. This is the initial presentation, sweet process and process. This is the patient vehicles at the third week follow-up, and this is the final outcome with the high dose steroid therapy. So the take-home message is we have as a physician, we have the effectiveness of the early corticosteroid therapy and effective patient counseling to the adherence to the treatment as well. Thank you so much.
Any questions? Can you give any other option other than steroids?
Yes, we can, depending on the severity of the case, we can start with the NSAIDs alone and then we can move to the steroids. And in this case, with patient was resistant, she needs to follow ups as well. So we have to go for high dose corticosteroids according to the body weight.
Assalamualaikum. My name is Dr. Abdullah, postgraduate resident, Margaret Hospital Complex, and I'm going to present on the outcomes of safe trabeculectomy approach, our case series evaluating IOP control and complications. For the background of the study, the objectives were to evaluate the efficacy and safety profile of TRAP with MMC in a tertiary care hospital. We aim to report the IOP visual outcomes and complication rates over a 2 years follow-up period. The study was retrospective case series analysis, and the sample size 19 eyes of 19 eyes of 15 patients. Follow-up after 2 years from 2021 to 2025. Baseline practices, mean IOP was pre-op was 27.6 with ranging from 98 to 36 millimeter of mercury, and pre-operative vision was ranging from counting finger to 20 by 30, 6 by 9 in Snellen number. As we noted that from pre-operative to post-operative, the IOP is significantly reduced from 27 to 9.5 with stabilization over the years. Then, pre-operative mean IOP of all the patients were 27 millimeter of mercury with 1 year mean of 111 millimeter of mercury. That shows a 57.2% reduction, which was significant and sustained. Reduction in IOP. The visual stability was maintained within one Snellen line at 1 year post-op. And as we noted the vision loss, there was a minor reduction in visual acuity in 4 patients, primarily due to cataract progression, which is a known sequelae of filtration surgery. Now, talking about blood morphology, then most patients have diffuse functioning blood, 70%, with 30% having cystic functioning bloods. 100% of the eyes demonstrated functioning blood at 1 year follow-up, indicating excellent surgical success. The early complications were hyphema, shallow AC, and in 5%, only 1 case had Seagal's positive. The late complications were blood needling, cataract progression, and there were no endophthalmitis, which is a negative factor we noted. The surgical success rate was 94.7% with IOP less than 21 millimeter of mercury, out of which 89.4% had complete success, requiring no medications. As we come on the discussion, the efficacy is confirmed after our results align with the major international studies with 57% IOP reductions comparable to the tube versus strap study benchmark. And for the manageable safety, the complication profile was favorable. Early hypotony and hyphema were transient. And 5% suggest intraoperative titration MMC exposure time 2 to 3 minutes. There's a short brief clip of surgery performed by my supervisor, Professor Dr. Ziaul Nazmi. I just observed and the follow-up period. As you see, a palectomy is being performed. Video is due to constraint of time. We have fast forward the video. and conjunctival flap is being dissected and scaled flap is being raised. Now you can see the sutures are being applied. Now here we will check the patency of the flap and meta sutures, the releasable sutures are being applied. Now the conjunctival closure is being done, and in the end we would like to check the patency of the flap. Coming on the conclusion, flap with MMC remains a highly effective and safe procedure for lowering IOP in our population. Thank you.
What's your duration? The success rate is 89% versus 94, I think. What's the length of follow-up?
Length of follow-up goes up to 2 years.
So does it mean up to how many percentage of patients? You need to divide how many had 2 years and how many had less than 2 years. So the timing is the essence.
Majority of the patients showed up to the 2 years. We had the record, and this was performed at our own hospital by Professor Dr. Ziaul Malik.
And what's the percentage of MMC used?
0.02%.
0.02%? Wow. We use 0.5% in the United Kingdom, so I'm surprised. Are you sure it's not is it not for the needling you use that?
No.
What did you use for needling?
Sorry?
What antimetabolite you use for needling? You said 5% needling.
5% needling, yes. We used it.
What did you use to needle? Do you use 5FU or MMC?
MMC. We use MMC, 0.02 milligram per ml.
For needling and for the trap?
Yeah. We basically use it in subconjunctival area, and before raising the flap.
No, I get it, but for needling, use low concentration of MMC in comparison to tuberculotomy.
No.
Thank you.
And what are the ages of the patient?
Mostly, in the inclusion criteria, mostly patients were from 18 to 60 years.
Okay, mostly the results show that you showed that 86% it's a very high percentage of success.
Qualified.
Normally, we don't see such a good success after TRAP. It's probably not even with AGP graph. But here, what is the main difference of the procedure which resulted in this such a good results?
First of all, we were very concerned that we used mitomycin C, that proper follow-ups, and secondly, that the other thing was we did not give any follicle incision as well in the trial to avoid any future outcome.
I think the follow-up period is of the essence, so I don't think they've looked at the duration of follow-up, especially the 18-year-olds. Obviously, you don't expect such a good success anyway, but I don't expect
Most patients were middle-aged.
But you need to show how many were followed up, or what length of time.
I got it.
And the MMC is the crucial part in your talk. You need to mention what percentage. Thank you.
For a talk on efficacy of injection progesterone in our
Dr. Aisha Muzaffar, Kochi resident at War General Hospital. I am presenting on behalf of my colleague Dr. Hannah, who will make it due to certain health issues. Am I on? The topic of discussion is effect of intravitreal ranibizumab in retinopathy of prematurity in terms of reactivation.
Aisha, Dr. Hina Khalid is not here. You are presenting on her behalf.
Yes, sir.
After permission, yeah.
So from my supervisor, he asked me to do it.
Okay, but you will not be testing for any.
Yes, sir.
I declare no conflict of interest. As we all know, ROP is a vasoconstrictive disorder of the developing retina and it is a major cause of childhood blindness. Since VEGF plays an important role in the neurovascular phase of ROP, so treatment with anti-VEGF is justified in selected cases. The rationale behind the study was that before the sad incident of post-intravitreal injection related endophthalmitis throughout Punjab some time back, we were using intravitreal bevacizumab in selected cases of ROP. But after that, the restrictions on bevacizumab, ranibizumab injection were started. However, we observed reactivation of this disease in many cases, which led to the start of this study. Moving on to the reactivation of ROP. The signs of disease worsening after an initial period of regression is defined as reactivation. The signs include appearance of new ridges, the lines, tortuosity of vessels, dilatation or extraretinal neovascularization. A screening criteria for this study was proposed by Propera. We broadly classified the groups into the participants into two groups. The first one was the group where babies were born before 27 weeks of gestation. They were screened at 31st weeks post-menstrual age. The second group was where the babies were born after 27 weeks of gestation. They underwent first screening at the age of 4 weeks chronological age. The inclusion criteria include the treatment naive ROP patients who hadn't received any new treatment before, patients with type 1 ROP, and those with aggressive ROP. The patients with stage 4 or stage 5 disease are excluded from this study. 38 patients qualified the inclusion criteria for treatment. 28 patients had AROP and 10 had type 1 disease. The methods used to diagnose were binocular indirect ophthalmoscopy or via the red cam. We started with taking an informed consent from the parents of all infants before IVR injection. The procedure started like we instilled topical and anesthetic eye drops, then intravitreal ranibizumab was given in the dose of 0.25 mg per 0.025 cc at a distance of 2.5 to 3 mm from the limbus. Post-injection antibiotic eye drops were also instilled. The treated eyes were followed up closely weekly or more frequently than necessary. The data extracted from the participants was their gestational age, the gestational age at first injection, gestation age, rescue therapy, the interval between the initial and rescue therapy, their birth weight, stage, and zone of ROP. The statistical analysis included percentages and frequencies were calculated, mean and standard deviations were derived, and independent t-tests for comparison between the groups were done. As you all can see the results, the patient with AROP, 100% of them had to undergo laser treatment following the first injection. So, whereas those having type 1 disease, 60% had to undergo laser. My conclusion is that although IVR is beneficial as an initial treatment for type 1 ROP or AROP, a long-term and regular follow-up until complete retinal vascularization is recommended, as there are chances of reactivation after the initial regression. So, the role of anti-VEGF is still evolving and requires more study to be done on it. Reactivation rate after initial IVR for type 1 ROP and AROP were assessed, and rescue therapy need is reported. These are the references. Thank you.
Question.
So you gave the injection at 2.5 to 3 millimeters.
Yes.
Or is it 1.5 to 2.5?
We gave it 2.5 to 3 millimeters.
Okay, and okay, so
actual distance is the half of the adult distance. It's not never be more than 2.
Otherwise, it may rupture any of the droplets left of the impression. I think it's more which you have written. It should be less than. Okay, we move on to our next speaker. Thank you. Momina Malik, please be here.
Assalamualaikum, I am Dr. Mohammad Rustam, third year ophthalmology resident from Lahore General Hospital. The topic of my presentation is effect of trabeculectomy with mitomycin C on RNFL thickness and central macular thickness in patients of primary open problems.
I think you started again. Just make this counter again. Incoming se log.
Topic of my presentation is effect of trabeculectomy with mitomycin C on patients of primary open glaucoma. So I claim no conflict of interest. So introduction, glaucoma is a chronic progressive optic neuropathy with characteristic visual field defect and raised IOPs are the major risk factor and it leads to reversible blindness. Trabeculectomy is a glaucoma filtration surgery designed to reduce the intraocular pressure by creating a fistula that facilitates the aqueous outflow from anterior chamber to the subclavian space. It has been recognized as the gold standard surgical treatment for uncontrolled glaucoma, and post-operative fibrosis is prevented by using anti-fibrotic agents like mitomycin C and 5-fluorouracil. So the effect of trabeculectomy on the ocular anatomy and ocular structures has been studied. So rapid decrease in IOP causes structural changes in the posterior fold and shortening of the axial length, anterior movement of the laminate fibrosa, and reversal of the optic nerve cupping and increased central macular thickness. These are the effects which have been observed after trabeculectomy. So the objective of my study is to determine the effect of trabeculectomy with mitomycin C on retinal fiber layer thickness and the central macular thickness. It was a quasi-experimental study in the materials used: oscillate Hextide application tonometer, Bonnell lens, Zeiss bone mirror, OCT machine, Zeiss series, and automated perimetry, Zeiss Humphrey field analyzer. The study is being conducted in Department of Ophthalmology, Lahore General Hospital, and the total duration of my study is of 1 year, and it's an ongoing study since April 2025. Non-probability sampling technique was used. After for comparison of pre-op and post-op OCT of the patients, trabeculectomy causes a remarkable decrease in IOP, which causes structural changes in the posterior fold, like shortening of the axial and the anterior movement of the laminate fibrosa, and also increase in the RNFL thickness and central macular thickness. So basically, right after the trabeculectomy, axonal stasis gets reversed, and that causes a transient increase in the RNFL thickness. But in long run, trabeculectomy causes decrease in RNFL thinning or degradation. So in long run, it causes decrease in thinning of the RNFL. And central macular thickness also transiently increase, maybe because of post-op inflammation, but it subsides after 3 months of the procedure. A transient increase in the central macular thickness in the first week to first month after TRAP, then subsides by 3 months, and RNFL thinning slope basically. Early course of tangent increase in RNFL thickness noted, but in the long run, RNFL thinning slows down after tracheectomy. Limitations of my study was it was a small study and it was a single center study in heterogenic. So the takeaway is IOP lowering causes structural changes and slow down the production of early and performance. Thank you.
These sessions are for the residents. The residents, they are encouraged to be interactive. They should ask the questions.
वैसे जब हमने प्रोसीजर किया है ड्राइव विद एमएमसी तो उससे कितना एक्टिवेशन हम लेते हैं जिसमें हम ये फिटनेस वगैरह जो है उसको नोट करते हैं
Almost usually first week, then first month, then after 3 months, then 6 months, then 1 year. के वेलोसिटीज को हम कंपेयर करके RNFL थिकनेस में कितना स्लो डाउन हुआ है, RNFL थिनिंग कितना स्लो डाउन हुआ है ऐसी एंड सर्टेन रेगुलर थिकनेस को भी इनिशियली में राइज इनिशियली में
सिग्निफिकेंट फिक्स टाइम पीरियड है कि इसमें भी आगे कोई सिग्निफिकेंट चेंज है वो
बेसिकली हमने ये स्टडीज इस पे हुए हैं तो ट्रांजिएंट इंक्रीज CMT वगैरह को मैकुलर एडिमा से हम कहीं मिस डायग्नोस ना करें, मिस इंटरप्रेट ना करें, इस बेस पे हम उसको फॉलो करते हैं पेशेंट को और RNFL थिनिंग इतना स्लो डाउन होगा।
अच्छा, परसेंटेज पे आप फिगर दे सकते हो कितना परसेंट कितने IOP रिडक्शन के साथ RFNL थिकनेस का?
सर बेसिकली ongoing study है तो भी फाइनलाइज।
Okay, thank you. Now we move on to next speaker, Redma Shante, on the topic unveiling.
I'm Dr. Redma Shante, and today I'll be presenting Unmasking the Great Masquerader. So our case begins with So our case begins with a 49-year female who presented to the OPD on 5th April 2025 with a complaint of bilateral gradual progressive decline in vision more marked in the left eye for 2 weeks. The decline in vision was also associated with bilateral floaters and periocular pain. Pain was gradual in onset, dull in character, non-radiating and mild in severity. There were no aggravating or relieving factors noticed by the patient. Moving on to the past history. In the past ocular history, the patient had multiple similar episodes which were treated symptomatically with eye drops. Unfortunately, no investigations were performed. In the past clinical history, the patient had frequent episodes of non-specific joint pain. The remaining history is unremarkable. On examination, in the general physical examination, the patient was widely stable. On ocular examination, the visual acuity of the right eye was 612 partial and the left eye was 636, with no improvement in the best corrected visual acuity. On anterior segment examination, bilateral cornea were clear, the conjunctiva of the left eye showed mild congestion, pupil of the right eye was brown, regular, reactive, while of the left eye it showed posterior sinus. The anterior chamber of the left eye showed +1 cells, there were bilateral early ventricular changes. The anterior vitreous of the right eye showed vitritis +1 and the left eye showed vitritis +2. On posterior segment examination, posterior vitreous of the right eye showed vitritis +1, left eye showed vitritis +2. On frontoscopy of the right eye, there was a vertical CD ratio of 0.2 with an ERM. The peripheries were unremarkable, but in the left eye, the view was hazy. Based on this, we made a differential diagnosis of intermediate uveitis, either due to an infective cause, an inflammatory cause, or idiopathic, for which we had to consider ocular TB, sarcoidosis, syphilis, multiple sclerosis, autoimmune disease, or past tinnitus. Our initial treatment began with topical steroids and cycloplegia. Meanwhile, we had requested some surgical investigations which were ocular and systemic. In the ocular investigation, we have performed OCT macula, which showed bilateral ERM, B-scan showed bilateral high vitreous echoes with flat retina, and the systemic investigation, the CBC was unremarkable, the HbA1c was 7.1%, CRP was negative, the quantiferon TB Gold Plus test came out being negative, the chest X-ray was normal, serum ACE however was elevated, autoimmune profile was unremarkable. So what's next? Is this idiopathic or are we still missing something? We sent the patient to a neurologist to rule out multiple sclerosis and neurosyphilis. One test was still remaining, and that was syphilis screening. The rapid plasma reagent test was negative, while the fluorescent treponemal antibody absorption test was positive. So now our diagnosis shifted to intermediate uveitis secondary to ocular syphilis. Our management had changed to a multidisciplinary approach. While managing the ocular pathology, we also had an infectious disease specialist on board. We continued topical steroid, periocular steroid injection, IV ceftriaxone course as recommended by the infectious disease specialist. Initial follow-ups were done weekly and then 2 weekly when the IV ceftriaxone course was completed. So what happened? There was reduction in the brightness and the visual acuity had improved. We also planned to perform HIV testing. So the take-home message is, in our society, social taboos and stigmas hinder diagnosis. A physician's role is to uncover the underlying cause so that timely intervention can prevent systemic consequences. Thank you. Any questions? How did you monitor the response to syphilis? Okay, in syphilis, we can perform the non-treponemal test, which include the VDRL and the RPR. So we do them to see if there is any response to therapy, because the treponemal test will remain positive throughout life.
What is the differential diagnosis?
So basically, it was a case of intermediate uveitis, and we had to consider either if it's idiopathic, it's an infective cause or an inflammatory cause. So although most common is idiopathic, so we had to consider past penitis, but we still had to rule out the infective or inflammatory cause before starting steroids. We did not get any positive response, and our treatment was not improving. So one last test was left, that was syphilis, so we moved on to that.
Any other question from the audience?
You mentioned that serum ACE levels were higher. So what was the cause? Are there any indications that serum ACE might be related to syphilis, or could we move towards diagnosis of sarcoidosis?
Okay, so sarcoidosis will have certain systemic features, ocular features, and certain lab tests as well. Systemic features will involve involvement of the lungs, there will be parenchymal infiltration, bilateral hiatal lymphadenopathy, or pulmonary fibrosis. Neurological consequences, meningitis, cranial palsy, pituitary gland involvement. In the eye, there are 7 typical things, for example, button fat capes, trabecular mesh all of those. So basically, your question that ACE was elevated, yes, it could be in sarcoidosis. We did not see any systemic features or ocular features, so we would move towards them. It could also be increased in TB, syphilis, HIV, nephrotic syndrome. See, yeah, it's not visible.
Did you find any systemic features of syphilis in the patient?
No, we did not.
Because FDA remains positive for life once it comes positive.
Yes,
so
it does.
Would there be any other reason for the flare-up or active presentation of the patient?
So, we did not find any active symptoms. Sorry, what was your question? Why was there any reason of flare-ups?
Yeah, because FTABS once it comes positive, it remains positive for life.
Yeah, it does.
And it is quite possible that acute presentation of patient is not due to syphilis.
Yes.
So, did you find any other possible reason for the presentation of the patient?
No, we did not. No, we did not.
Okay, thank you very much, Dr. Shastri. Now we move on to our next speaker, Dr. Sarah Harun. Is she here? Okay. The silent scalp consequences of protein closure non-ophthalmology. Skill.
Bismillahirrahmanirrahim. A scalpel that never cuts is silent. And silence in surgery means lost opportunities, lost skills, and lost confidence. I am Dr. Sarah Harun, second year FCPS trainee in Jinnah Hospital, Lahore. Today I am going to discuss the consequences of OT closure on ophthalmology resident skill. So CPSP intermediate module is designed to ensure that trainees acquire fundamental surgical skills before progressing to fellowship level training. The curriculum mandates exposure to a range of anterior and posterior segment surgeries like corneal surgery, and glaucoma surgery, trauma repair, vitreoretinal surgery, and cataract extraction techniques. However, unexpected disruptions like prolonged corticosteroid due to administrative or infrastructural issues can critically impair the surgical care. So my objective is to emphasize the consequences of corticosteroid on residents' skill development. So the study was a descriptive audit comparing the CPSP required minimum case exposure according to the IMM module 2015 versus actual surgical exposure at the second year residence. So the study setting was Department of Ophthalmology, Jinnah Hospital. Data was collected according to the resident's logbook or OT activity report. So findings were compared with the CPSP required surgical benchmarks and descriptive analysis was performed and departmental approval was obtained. So this is the table format showing the level of competency and number of cases in the first year regarding the use of lasers, operation theatre equipment, anesthesia, traditional surgeries, corneal surgeries, and cataract surgeries, glaucoma, VR surgery, trauma, and rehabilitation. And this is the level of competency and number of cases in the second year, corneal surgery, cataract surgery. So my conclusion is the number of intraocular cases performed or observed during these years were almost 0 to none. However, extraocular cases were performed in the neuro-OT with the limited access for only 1 day. So it significantly impacted our competence, and we were unable to attain the basic surgical skills, unable to fulfill the CPSP requirements for appearing in IMM, and delayed independence, burnout, psychological stress, and perceived inadequacy. So my recommendations are, these recommendations should have been given by the government, CPSP, or the department by itself, but they failed to do so. So my recommendations are simulation-based training like paperweight labs, IC simulators, cross-institution rotations, temporary placement in centers with functional OTs, structured mentoring with one-to-one skill development, extended training period to compensate for the months we have lost, policy interventions, mandatory minimum surgical days per month. So we are only left with extended training period option as other options are not feasible now. I strongly request to implement these recommendations in the future so no one else suffered like us. I was among the topmost students in our class, but due to these circumstances, I feel like I am left behind. Being a female, I am not able to attend the surgical camp as males have this opportunity as well. And I might not be able to appear in the IMM exam as per CPSP requirement criteria. So who is responsible? That's all. Thank you so much, Dr. Sarah.
Very interesting. That's good. But your recommendations are also extending the training period. How will it affect the overall?
सर जो 2 साल में हमारा लॉस हो चुके हैं, मैं सेकेंड ईयर रेजिडेंट हूँ, मतलब मेरा क्वार्टर 4 चल रहा है, तो जो मेरे लॉस हो चुके हैं वो यही ऑप्शन एक बाकी रहेगी, अगर एक्सटेंडेड पीरियड हो जाए या बाकी ऑप्शन तो जो टाइम गुजर गया वो तो नहीं आ सकता वापस, कोई अब उसका फायदा नहीं है, बाकी सिर्फ यही ऑप्शन बाकी रहता है कि एक्सटेंडेड पीरियड कर दिया जाए, ये सिर्फ बेहतर ऑप्शन अगर CPSP हमें देती है तो वो अप्लाई किया जा सकता है। सर वो खुद कॉम्पेंसेट करें कि हम तो अवेलेबल थे, हमारी हम फुल डे आते रहे हैं, हर दिन आते रहे हैं।
चलिए OSP ने इसके लिए बड़ा अच्छा एक काम किया है, they have created a wet lab in OSP house।
जी सर वो अभी इनिशिएट हुआ है जी, मतलब सर वो 2 इयर्स तो हमारे वेस्ट थे ना, तो स्टार्ट ये हुआ है बिल्कुल 1 to 2 वीक्स बैक।
Unfortunately, not at the CPSP।
जी
CPSP
शायद CPSP को पता भी ना हो कि हम कितना सफर कर चुके हैं।
So it is to highlight these CPSP so that
Thank you. We move on to our next speaker, Fazia. Eye strain, musculoskeletal discomfort and stress among possibilities and observations. If you please see here. Dr. Rajia Nabi. So, which should be Shamil for the talk on frequency of convergence insufficiency in patients with Parkinson's.
Assalamualaikum. My topic is frequency of convergence insufficiency in patients with Parkinson's disease. Parkinson's disease is a chronic neurodegenerative disorder that significantly affects the motor, sensory, and the visual functions. Patients with Parkinson's disease commonly complain of the impaired visual functions and difficulty reading despite having a good ability, and even then they face difficulty while reading. So impairments in the vergence control related to the attention and slow separating movements in Parkinson's disease may predispose patients to developing the convergence insufficiency. So during binocular period, visual pathways interact in such a way that there is a deficit at the neural level, so it can affect the convergence insufficiency in the Parkinson's disease patients. So we thought that it should be ruled out. So objective of the study was to determine the frequency of the convergence insufficiency in patients with the Parkinson's disease. A descriptive type cross-section study was carried out. Data was taken from the General Hospital and the Services Hospital, Lahore, for 4 months, and the sample size of 80 was calculated. Convenient random sampling technique was used. So we included the patients between 40 to 70 years of age. Patients were already diagnosed with the Parkinson's disease, and patients who were able to cooperate with us, and the scale equity was taken as 20/40. Individuals with the refractive errors greater than 5 diopters were excluded. Patients suffering from any neurological disorders were also excluded, like stroke, or patients receiving any mental disorder were excluded. Patients who were taking medications which can affect the binocular vision were also excluded. So data collection process began after taking the ethical approval from the University of Lahore. And we collected the data through demographic details for the questionnaire, and the instrument RF ruler was used to measure the convergence insufficiency. So we found out that there were 80 patients, and 42 were men and 38 were women in the age of 40 to 70 years. And we found out that there was a high number of convergence insufficiency in the patients suffering from the Parkinson's disease. This was the demographic data. So this is the basic value of RF ruler that shows that almost every patient had the convergence insufficiency which were included in the Parkinson's disease. Minimum was 12 centimeter and maximum was 34 centimeter, and the duration of Parkinson's disease correlation was also found out. So this was the relation of the Parkinson's disease with the convergence insufficiency, which shows it is significant, and our p-value was less than 0.05, and it shows a positive correlation with it. So this is the frequency range distribution which we made it on the basis of the convergence insufficiency. That was not a universal criteria, just to make a forward study we categorized in 3 regions. That was 10 to 18 centimeters, 35 patients, 43% patients had 18 to 24 centimeters, and 12.5% had a severe convergence insufficiency. A scatter plot was also analyzed, and it was found that there was a positive correlation with the Parkinson's disease and the convergence insufficiency. So it was concluded that there was a significant correlation, and it can impair the real disease and it can impact your daily life. So it is recommended that the early management should be carried out, and clinicians should consider a routine examination of binocular vision assessments in the Parkinson's disease patients. Thank you. Is any questions?
As per my understanding, it is a disorder of visual ganglion. Basically, that is supranuclear palsy. Were these patients having any other symptoms like intermittent diplopia? Was it considered in the study, or just you were examining convergence insufficiency?
No, we just examined the patient had the symptoms. We also made him to fill the questionnaire related to the convergence insufficiency that related to different questions like difficulty in reading and all these. But over
But they were
diagnostic,
suffering from any bradycardia, were there any intermittent diplopia there?
no. We just ruled out the convergence insufficiency.
Just
we just
your
yes,
question
yes,
was
we just
concerned about
focused,
convergence
yes, we just used the RAF ruler as an instrument. Our diagnostic criteria was on the basis of the RAF. So we just focused on the convergence insufficiency.
As per your chart showing that RAF ruler, it was for majority of the population, it was in near to normal range.
Yes. No, it's
not. It is ideally it should be 8 to 10 centimeters.
Yes, yes.
So for a major person,
it was also associated with the duration of the Parkinson's disease. As the duration progresses, the convergence insufficiency becomes evident.
okay, was any data concluded that whether they were using any medications for Parkinsonism and with these medications their condition was improving or not?
No, of course, patients were using, because it was in our including criteria that we will only include the patients using Parkinson's disease medication, not any
In
other.
literature, it is written that
Yes.
if patient is having convergence insufficiency, the
Yes.
only proven treatment is levodopa.
Yes.
So, if Parkinson patient were using these levodopas, even after using levodopa, they were having convergence insufficiency.
Yes.
Okay, thank you. Now we move on to our next speaker, Zainab Umar, for a talk on iceberg spectrum.
So my patient is a 34 years old female. She is a resident of Sheikhupura. She presented with complaint of doubling of vision for 1 month, upper deviation of left eye for 15 days, and blurring of vision left eye for 2 days. The past medical and surgical history was unremarkable. She has been wearing glasses for 8 to 9 years. The past drug and family history was insignificant, and the patient reported no history of trauma. So according to the patient, she has been having on and off doubling of vision on down days for 1 month. She now noticed an upper deviation of left eye for 15 days, which was associated with blurring of vision left eye for 2 days. The patient said that she has been having on and off vertigo for quite a few years now, and was now associated with projectile vomiting for 2 days. The patient was vitally stable. Moving on to the examination, the best corrected visual acuity was 6 in right eye and in left eye it was 6/9. The ocular adnexa, pupil, cornea, anterior chamber were within normal limits, and intraocular pressure was 12 millimeters of mercury in right eye and 13 millimeters of mercury in the left eye. On diplopia charting, the patient reported diplopia on adnexal depression and a downward gaze. To begin with the orthoptic assessment, we noticed a slight compensatory head posture of the patient. The Hirschberg was central in the right eye, whereas in the left eye it was displaced 5 to 10 degrees inferior and 5 degrees nasally. Uncovering the right eye, the left eye moved slightly downward and inwards. And on uncovering, the right eye moved upward and inward to take up the fixation. On Krimsky test, there was left eye hypertropia of 12 to 14% diapers, and an alternate exotropia of 6% diaper was noted. 10-degree cyclotorsion was noted on double Maddox rod. And on Bell-Shosky 3-step test, left eye hypertropia worsened on the right gaze, and it improved on the right head tip. The extraocular movements, including the saccades and pursuits, were all normal, except that there was an inferior oblique overaction of the left eye. So we moved on to check the optic nerve functions. RFPD was negative in both eyes. Best corrected visual acuity was 6.6 and 6.9 as previously mentioned. The color vision and contrast sensitivity was normal in both eyes. When we performed the confrontation visual fields, it was normal in all quadrants in the right eye, whereas in the left eye there was slightly constricted temporally. The fundus examination of both the eyes was within normal limits. So the investigations that we requested were Hess test, MRI brain with contrast, and visual fields. The Hess test confirmed the superior oblique palsy of the left eye. But what the most commonly presented superior oblique palsy is congenital. But in this case, the MRI brain with contrast showed the iceberg, which was underneath. It was an intracranial mass of posterior cranial fossa. This is the MRI, and the arrows are pointing towards the lesion. The impression was that the mass was in the posterior cranial fossa, was lying in the midline. In the fourth ventricle, it was compressing the brainstem.
The mass was then extending superiorly and lying in the occipital region, causing dilatation of third and lateral ventricles. So the patient was urgently referred to the neurosurgery department where her BP shunting was done. And then later MR spectroscopy was performed and a diagnosis of intracranial epidermoid cyst was established, which is a very rare congenital lesion, and it typically presents in the middle age due to the mass effects on the adjacent structures, which was same the case in our patient. Here the vision fields, it shows normal vision fields in the right eye, whereas in the left eye is slightly depressed temporally. So if you look at the optic tract lesions, so the only monocular temporal crescent defect of the contralateral eye is seen when the lesion is compressing the front of the calcarine cortex, which is quite comparable to the MRI of our patient. The mass is compressing the right part of the calcarine cortex and causing the visual field defect, the temporal crescent of the left eye. There's another picture showing the similar lesion. So the diagnosis of intracranial mass leading to fourth nerve palsy and visual field defects was established. And in the management, the patient was referred to the neurosurgery department and regular follow-ups were advised. And for the symptomatic relief, prisms were advised for review. So the take-home message is thorough examination of all the cranial nerves is very important. Complete history taking can lead us to proper management and diagnosis, and an early referral to the concerned specialty will lead to timely management. Thank you. Any questions? Yes, please. So yeah, intracranial pressure was raised, but the patient did not have the papilledema, so it is not always necessary that the patient presents with papilledema. It usually takes hours to days for papilledema to develop. And even in the acute phases, sometimes the nerve sheath does not have the enough transit time to so that the papilledema develops.
Can we offer any other options to the patient if her diplopia and discomfort persists?
Yeah, good question. So basically, we just gave her a symptomatic relief of prisms and referred the patient to the neurosurgery department, and they are going to plan the surgery. Because in this particular case, when the patient has started having the mass effects, the lesion has to be removed. So then we are going to follow up the patient if the palsy is reversible and if the patient is relieved, then maybe we will do nothing. But if the symptoms persist and the palsy persists, so maybe we are going to go for Harada procedure, which is the option for fourth nerve palsy.
So, is there any involvement of the facial nerve because the posterior
Yes,
vein
absolutely. Yeah. Because for the facial nerve, I had to show the picture of the whole patient and the vaccinator and all. We did check for the facial nerve; it was all normal, and the patient did not give she was not willing to show her face, so I did not say.
But there is involvement of the facial nerve. And
No
also,
involvement. There was no involvement in the patient. Yeah, facial nerve examination was normal.
and the vestibulocochlear nerve, vestibulocochlear nerve, hearing impaired.
No, hearing was not involved.
Thank you.
Okay, very well. And now we move on to the next speaker, Vajia Rafi, for talk on surgical outcome of external PCR under local anesthesia tertiary hospital. A prospective cohort study. Mr. Dahin, for the talk on eyelid reconstruction using full thickness skin graft in post-traumatic
and the scarring of the eyelid after a trauma, burns, infection, or the previous surgery. It leads to the exposure keratopathic, tearing, and a cosmetic deformity. Early reconstruction is essential to prevent the long-term ocular complications. So let's talk about the case now. An 11-year-old child presented to our department with the complaints of the difficulty closing the left eye, watering, redness, and difficulty in blinking. Child has a history of the road traffic accident 3 months ago. After that, he sustained multiple facial abrasions and the upper iris soft tissue loss. He received a primary wound repair from some local hospital, and but over the next several days, he developed the progressive scarring and the contraction of the iris skin, and he developed the cicatricial atrophion of the left upper eyelid. So, on examination, as we can see in these pictures, that the
eyelid was vertically shortened due to the 10-scar scheme, and the palpebral conjunctiva was also exposed, and there was also a lag ophthalmos and dry contact. So the diagnosis of the post-traumatic left upper eyelid superficial atrophion was made. And after the detailed history and examination, eyelid reconstruction was planned using a full thickness skin graft under the general anesthesia after the adequate pre-operative preparation and with the collaboration of the plastic surgery team. So during the surgery, as we can see in these pictures, that all the previous scar tissue and atrophion was released to ensure the full eye closure. Then the skin defect was measured, and then the graft was harvested from the left median arm according to the size of the skin defect. Then the graft was shaped appropriately and sutured in place with the fine sutures, and then the aseptic dry-over dressing done. So on follow-up, as we can see in this post-operative picture, the graph showed the good vascular uptake, appearing to being healthy and stable. Eyelid margin position was markedly improved, and eyelid closure was more complete, reducing the risk of the exposure. And there were no signs of the graft necrosis or infection. So coming on the discussion, traumatic eyelid skin loss in children, it can lead to the rapid scarring and the superficial atrophion due to the active mood healing response. Failure to correct can result in the chronic exposure, corneal ulceration, and vision impairment. Full thickness skin grafting is a preferred technique in such cases because it provides an adequate skin replacement which undergoes a minimal secondary contraction, and it offers a better color and texture match. So on conclusion, full thickness skin grafting, it is a reliable and effective method for correcting the post-traumatic superficial atrophion in the pediatric patients. Eyelid surgical management helps to restore the eyelid anatomy, it protects the ocular surface, and it ensures the favorable long-term outcomes. Thank you. Any questions?
After graft or arms and legs, so from which other places can we take?
Because the arm skin closely matches the eyelid skin in the color, texture and thickness, and it is also the less hair bearing area, and it also has a minimal subcutaneous fat. So that's why we prefer it.
Asha, did you perform any vascular anastomosis? If not, how did the graft flow reflect back?
No, we do not do any vascular anastomosis. But as we graft take its blood supply in the 3 stages from the wound bed. The first stage is the plasmatic imputation, in which the graft absorbs the nucleus by the defilate from the wound bed, and in the second stage is the inoculation, in which the capillaries of the graft align with the capillaries of the wound bed, and in the third stage angiogenesis starts, in which the vessels grow into the graft, the skin of the other eyelid for the graft.
Okay, thank you very much for your nice talk. And now we move over to our next speaker, Azish Mushtaq, for a talk on rare case of Bentley cell infection in upper eyelid of child.
I am Dr. Azish Mushtaq, PGR Ophthalmology, Vishwavana Medical College Hospital. Today I will talk with you people a rare case of Bentley cell infection in upper eyelid of a child. A 10-year-old boy presented to us in emergency room with a metallic foreign body embedded in the right upper eyelid for the last 1 hour, which was associated with redness, lacrimation, and mild upper eyelid swelling. First of all, I would like to tell you that I am sharing this picture after taking proper consent from the parents. On examination, there was a metallic foreign body was present on both the outer faces. Visual acuity was 6/9, body was clear, and there was a gingival condition, and the lens was faded, pupil was round, regular, and reactive. Anterior chamber was well maintained, while left upper examination was unremarkable. To further investigate the case, we have advised X-ray skull plus orbit, anteroposterior, and regular view. On AP view, as you can see, there is an orbital foreign body was present on the AP view of the X-ray. But when we saw Lateral view of the X-ray skull plus orbit view assumed that it's a large enough. But the patient was not cooperative because he had anemia for child for further more examination. That's why we plan to explore this case under general anesthesia. Treatment administered pre-op that was a topical and systemic antibiotic and only iPad was applied. The patient was optimized and prepared for surgical removal of the foreign body under general anesthesia. Here the metallic foreign body was present on the upper eyelid of a child. But when we explored this case, we prepared and explored this case for the removal of foreign body. But surprisingly, when just we applied an enterobion clamp on the outer part of the metallic foreign body, it came very gently from the outer part of the eyelid. And just we applied enterobion clamp on the inner aspect and the inner part of the metallic foreign body came out. The interesting case is that they both are again very symmetrical on the outer and inner aspect of the eyelid. The post-surgical management was topical and systemic antibiotic was advised to that patient. What can be complications? They can cause pain, tenderness, adrenal, orbital cellulitis, and these can cause a chemical injury to the eye. If it can stay in the long term in the eye, it can ultimately lead to the scarring of the tissue. Thank you. Any question? And we can repair this case and manage this case with the help of the orbital surgery. Yes, this is a very interesting case. We were also very keen to know how they got. The child was playing with the AirPods and he broke that and he took that one piece and other piece ultimately got into that. The parents didn't know much more this case, but they have given this on this case.
You try to remove it without anesthesia, and if you try to remove it, it's pathetic. Maybe you could have used a magnet to remove it. Did you try or the patient?
The patient was not cooperative. He's the only child. He was not, and his parents are very much anxious, and he was not cooperative. That's why we plan to proceed and further dismanage this case under general anesthesia so that we can better assess and manage this case accordingly. Yes, if it's that it can cause a chemical injury to the eye because the foreign body, metallic, the air pod, they are made of the cobalt and they can cause a chemical injury to the eye. So that it's very necessary to accordingly dismanage and timely remove this metallic foreign body.
Okay, thank you very much. Now we move on to our next speaker, Sara Farooq, for a second talk on efficacy of history in Yes.
Assalamu alaikum. I'm Dr. Chakir Abbas, a third year resident ophthalmologist at Jinnah Hospital, Lahore, and today I present this paper on a clinical trial of povidone iodine ophthalmic solution versus natamycin for the treatment of fungal keratitis. As we all know that fungal keratitis is one of the leading cause of avoidable corneal blindness, particularly in developing countries, and in the regions like central and southern India, fungi account for 17 to 44% of the microbial keratitis cases. The challenge in treating fungal infections are that they are difficult to eradicate because the fungal hyphae penetrate deeper into the stroma. The standard care available is natamycin 5%, that is very effective, but often unavailable or can be prohibitively expensive in especially resource-dense areas. So, on the other hand, povidone iodine is however widely available and in many forms. Even the powder form can be made into ophthalmic solution and it can cost as low as $1 per bottle. In an unpublished pilot study in Manila, they treated 5 public corneal ulcers with povidone iodine 1.25% ophthalmic solution and the 5 cases were cured in average for 12 days for Physium Solani and 15 days for Mycelium Sterilium. So these results encourage us to compare the effectiveness of povidone iodine ophthalmic solution versus natamycin. So our study objective was to compare the effectiveness of topical 1.25% povidone iodine ophthalmic solution with 5% natamycin suspension for the treatment of small to medium-sized fungal keratitis. Our primary hypothesis was non-inferiority. The subjects treated with the povidone iodine do not have any inferior outcomes on average compared to the subjects treated with natamycin. Our study design was triple-masked randomized controlled trial with multi-center and study sites were Jinnah Hospital Lahore, Doctors Hospital Lahore, and Lahore Medicare Eye Hospital, and the duration was March 2022 to December 2025. Our total participants were 78 with 39 in mutual. Our inclusion criteria was age greater than 1 month old and culture positive for focal cornea ulcer or positive for Nassim. Our ulcer onset within the last 14 days and ulcer diameter of 1 to 6 mm square. Our exclusion criteria was failure of initial culture to show the presence of fungi, history of allergy to iodine, natamycin, and perforation of the cornea or sclera or any impending perforation, or any neurotrophic keratitis, or any recent use of a topical antifungals. So our treatment arm had a topical 1.25% povidone iodine ophthalmic solution, and our control arm had a topical 5% natamycin ophthalmic suspension. Our dosing schedule was initially very intensive. For first 3 days, it was 1 drop RD, and it was set on the 4th day, RD while awake and 3 RD while asleep, and it was further set on the 5th day to improve. 2 RD while awake until cured. Our efficacy endpoint was the epithelial defect less than 1 mm square, no stroma infiltrate or plaque. Our secondary endpoint was treatment failure. All ulcers were debrieded after the initial examination for cultures and smears, and subsequent debridement was left to the treating ophthalmologist's discretion. There were no serious adverse events or unexpected adverse events noted. Among the corrosive organisms across all the centers, the most common was Fusarium solani, 41.7% in one center, and Aspergillus flavus, and many unidentified imaginaceous fungus. There were significant differences in the mean ulcer size and treatment response across the 3 centers, partially due to varying approaches to the subsequent ulcer debridement. Jinnah Hospital and Doctors Hospital debrided daily, and Lahore Medicare debrided only at the presentation. So here is the table containing the result. As we can note in the povidone iodine group with ulcer size less than 2 mm square, 62.5% of the subjects were cured, and in ulcer size greater than 2 mm square, only 17.4% of the subjects were cured. And in natamycin, less than 2 mm square ulcer size, 100% of the subjects were cured, and in ulcer size greater than 2 mm square, 57.1% subjects were cured, concluding that natamycin was significantly more effective than povidone iodine, overall the p-value less than 0.01. Here's another table showing that treatment was according to varying centers, and here we can see that in povidone iodine group in Lahore Medicare Eye Hospital, there's 0% cure rate as they debrided only at the presentation and there was no subsequent debridement. However, in the natamycin group at the same center, 11 patients were cured. Here's another table study-finding data about the ulcer size. Both are performed better in small ulcers less than 2 mm square. However, the povidone iodine effectiveness dropped dramatically in large ulcers with 17.4% cure rate. Our primary hypothesis that the povidone iodine is non-inferior to natamycin is rejected, as natamycin cure rate was significantly better across all ulcer sizes. The findings suggest that povidone iodine penetration may be insufficient for the larger ulcer greater than 2 mm square. However, povidone iodine demonstrated reasonable activity in the smaller ulcer less than 2 mm square, achieving 62.5% cure rate. A prior study that used 5% of the povidone iodine has a reduced compliance, particularly from the singeing or decreased swelling frequency. Our study used 1.25% povidone iodine, which is better tolerated. So the center that did not apply that subsequent to presentation. Mean exercise for 4.2 millimeters achieved zero success in polygon iodine growth. We suggest that the effect of polygon iodine may be augmented by the second technique that overcome the penetration limitation. Further studies are recommended to further explore and qualify the effect of repeated vessel deployment on the efficacy of topical antifungal therapy, especially with agents like polygon iodine. So main takeaway is that adamycin 5% in the standard care and is significantly more effective than 1.25% polygon iodine. However, it can be effective in the ulcer that is 2 mm scale, and for the larger ulcer greater than 2 mm scale, every FSF is required adamycin and other effective antifungal as early as possible.
Thank you, Dr. Akhil. Thank you.
Assalamu alaikum. My name is Dr. Amna Muhammad and I am here to talk about comparison of laser versus ranibizumab in zone 2 retinopathy of prematurity. Before we begin our talk, I would really like to highlight the importance of this topic as a vulnerable group here are infants, those who are really vulnerable and if not led to proper treatment would lead their life in darkness. Thank you for your attention. What we know already about retinopathy of prematurity that it is leading cause of preventable blindness in children globally. It is characterized by retinal ischemia, the high zone 2 retinopathy. There is a treatment dilemma in zone 2 retinopathy of prematurity because there is established data and evidence about zone 1 and zone 3. However, there is a lack of consensus in zone 2 retinopathy treatment modalities as there is a debate about recurrent risk versus structural preservation of retina. So what do we already know about the treatment modalities of retinopathy of prematurity in zone 2? Laser photocoagulation is gold standard. It destroys, as we all know, it destroys avascular retina, but there are some risks associated with it. For example, complications with anesthesia, cataract formation, vitreous hemorrhage, hand myopia, and visual field loss. On the other hand, we have a newer alternative, anti-VEGF ranibizumab, that blocks pathological angiogenesis. It's better for retinal development and long term. Our study aim was to compare laser photocoagulation versus intravitreal ranibizumab for zone 2 retinopathy of prematurity. And what we wanted to study was for recurrence rate, mean for treatment, complications, and survival without active retinopathy of prematurity. The study design was randomized controlled trial done on multi-center hospitals and duration was 3 years. The participants selected after ethical board review committee approval was 26 infants. We divided them into 2 groups, group A and group B. Group A had laser photocoagulation as treatment modality and group B were injected with intravitreal ranibizumab 0.3 mg and 0.03 ml. Okay, so now how we did follow up was we did follow up weekly for first 1 month and then monthly for first 6 months. The primary outcome we looked were for recurrence of retinopathy of prematurity, need for special treatment, treatment failures, and complications. Our primary result was laser showed superior disease control in preventing recurrence rate. The recurrence rate of retinopathy of prematurity was higher in the ranibizumab group, and the need for switching treatment was higher in individual group as well. So we observed trends for the superiority of laser, and the missing data in knowledge was long-term structural data. Here you can see in the table the superiority of laser and results. And recurrence, switching treatment, complications, and survival without active ROP. Okay, so clinical implications and safety consideration I will talk about as a laser. The findings support laser as first line for zone 2 retinopathy of prematurity and a more potent anti-VEGF data emerges. Ranibizumab is useful when laser is not visible and it's also systemically safe. Long-term safety of anti-VEGF remains uncertain. The clinical trade-off. This is the main dilemma we were talking about earlier. We can not trade off the short-term benefits with the long-term benefits. So what we are going to do is you have to individualize the treatment for the patient. The limitation of the study was that we only started zone 2. There was a group imbalance. Ranibizumab group, the patients were 10 years younger, 100 grams smaller, and half of the patients were male as compared to group A. The follow-up was short and there was small sample size. I will recommend for next study for longer term follow-up and larger multi-center trials in Zoom, and topics of prematurity specifically. My conclusion and take-home message as interpretation is superior for preventing recurrence. Ranibizumab is valuable alternative. Choice includes trade-off immediate control versus long-term retinal structure, and we should always individualize treatment based on clinical scenario. Thank you. Any questions, please?
Why you use ranibizumab and not any other anti-VEGF?
We have data with other inhibitors and antibiotics. Thank you.
And how many lasers sittings do you prefer, or one sitting?
So it depends upon the
different type of cases presented by the including the posterior segment, anterior segment, oculoplasty, squint, everything was there. And very interestingly, the problems faced by the DGRs regarding their training due to closure of hospitals was also one. So it was a good contribution from all the hospitals and institutes where PGRs they are there, and I good to see very valuable and considerable presentation from all. The slides were good. Presentations, definitely every individual has its own slide. But it was a very good effort on the part of the supervisors. Your supervisor, they need to be appreciated that they have inculcated so much of knowledge and your way of presentation, and they have been various different topics. But one thing I must reiterate that case presentations, they are not going to be judged for any position. That's already, I think, conveyed to the residents. So, studies definitely they will. Thank you very much for your contribution. It's a good forum. And next, it would be on Sunday from 9 a.m. to 13. Again, it will be a post-resident, postgraduate 3 days. Thank you very much for your help.